So good evening, everyone. Thank you, Randeep. Thank you, organizers, for giving me this opportunity. Disparate from what my previous colleagues have spoken, this is more of an observational study, but it focuses on a so-called orphan disease. It's a non-clear cell metastatic renal cell carcinoma. And as we all know that it constitutes almost 25% of the metastatic RCC that we see in the clinical practice, and also is backed by the literature. The issue with this is that there are most of the pivotal trials which includes RCC would exclude non-clear cell histology, and hence there is no optimal standard of care. And if you dwell into the clinical, or rather the algorithms, it's still mentioned that the clinical trial is the best option for these patients. So this is an observational study done in Italy, wherein patients with non-clear cell metastatic renal cell carcinoma were retrospectively and prospectively studied with a combination of pembrolizumab and axitinib combination, and it's a part of a NEMESIA study, and it's a subgroup analysis of a phase of one rare observational study which was published in the Journal of Molecular Oncology. So this is the highlight of the study, that it's going to study about combination of IO plus axitinib in a metastatic non-clear cell RCC. As we all know, the non-clear cell RCC includes predominantly two group of histologies. One is the papillary RCC and second one is the chromophobe RCC. And the papillary RCC is of two types, type 1 and type 2, depending on the MET and the RET oncogen overexpression. The non-clear cell ones, the metastatic RCC, whatever the evidence which we have is very limited evidence, with most of the numbers of the trials includes 30-40 patients. The current standard of care includes data for nivolumab plus cabozantinib. There is a phase 2 study which is showing the overall response rates and disease control rates to the tune of 50 to 70%. There is a study of lenvatinib plus everolimus, which works across all the non-clear cell subtypes and again gives a disease control rate of 50 to 70%. Axitinib monotherapy, there is some evidence of disease control rate, and there is also evidence that pembrolizumab monotherapy is active, but the response rates of monotherapy with pembrolizumab and axitinib alone is to the tune of 30 to 40%. So let us look at this observational study. If combination of these two important drugs which are used in the metastatic clear cell RCC has any relevance in a non-clear cell histology. So this is again belaboring what I just mentioned. These are the NCCN guidelines which expound the current standard of care as far as the non-clear cell histology is concerned. And as you could see here, the preferred regimen is clinical trial. And as I mentioned here, there's a data of cabozantinib and sunitinib, and of course the other recommended regimens as has been mentioned here. Also, there is some data of bevacizumab plus erlotinib in a hereditary papillary renal cell carcinoma and leiomyomatosis with some impressive results. But again, there is no standard of care for these so-called orphan metastatic RCCs. So metastatic RCC, non-clear cell carcinomas constitutes almost 25% of the patients with RCC, very limited therapeutic options, and they have generally overall lower response rates compared with metastatic clear cell RCC. So this study aims to investigate the effectiveness and tolerability of pembrolizumab plus axitinib combination as a first line in chromophobe and papillary metastatic RCC. This study actually included only patients with chromophobe and papillary RCC, which constitutes almost more than 80% of non-clear cell histology, but there were 2 or 3 patients with sarcomatoid, not variant, sarcomatoid features, non-clear cell RCC as well. So the baseline characteristic, overall response rate, disease control rates, and the PFS and toxicity were retrospectively collected from 12 Italian referral centers from December 2020 to April 2023, and only patients with chromophobe and papillary histologies were included in this particular observational study. So these were the baseline patient characteristics. As you could see here, chromophobe and papillary are the one which are predominant. There were patients who had IMDC score of good, intermediate, and poor risk. Predominantly intermediate risk is what were included. Many of the patients had previous nephrectomy, or also some of them underwent cytoreductive nephrectomy, had a decent performance status for all three, and they had synchronous metastatic disease involving bone, liver, lung, and nodal disease. So these were the radiological response rate that you could see. CR rates were seen in none. You had a partial response of almost 43% in the overall population, and 16.1% in the chromophobe and 19.3% in the papillary histology. There was overall response rates of 43.7% at a group level, but at an individual level, the chromophobe one had 41.6% and 47.3%. And I think that probably allude to most of the previous data that we know, that the chromophobe are not the one which respond very well to the treatment compared with the papillary histology. So overall response rate by the histology, again amplifying in this particular bar chart, were 47.3% in the papillary subgroup and 41.6% in the chromophobe subgroup. Again, similar to what has been echoed in the previous phase 2 study which I just mentioned before. And the disease control rate, which includes partial response as well as stable disease, was hovering around 60 to 70% in the papillary histology and around closer to that in chromophobe histology as well. So the regimen was active in both chromophobe as well as papillary variant of the non-clear RCC, and fairly decent response rates and disease control rates. Again, this study is not powered to study PFS and OS, but the progression-free survival is around 10.8 months, and which is what actually you see in most of the non-clear cell RCC studies, except for the monotherapy with pembrolizumab and axitinib, where the PFS was almost 6 to 7 months. So this again is consistent with the observation that we had with the previous study, that the PFS was around 10.8 months. Median progression-free survival in the papillary variant again was 10.8 months. So the results were 25 to 30 eligible patients, fairly impressive disease control rates of 70 to 80% in both the subgroups, slightly inferior in the chromophobe versus papillary, and the partial response rates or the overall response rates of close to 50% in both the histologies. Again, the tolerance was fairly okay. 34.3% had to interrupt the treatment because of the immune-related adverse events. Grade 3 hepatitis, grade 3 hypophysitis, grade 3 diarrhea, grade 3 pancreatitis and asthenia were seen, and 12 patients interrupted temporarily because of axitinib due to persistent hand-foot syndrome and hypertension. So the conclusion of the study is that pembrolizumab axitinib combination could be an active and feasible first-line treatment options for patients with papillary or chromophobe RCC. And my comments would be that data is too small, but all metastatic non-clear cell RCC data is around for 30 patients. So maybe we could debate on that. It's again an observational study. We have a data of nivolumab cabozantinib phase 2 data has a similar disease control rate and overall response rates. The keynote 427 data, which is pembrolizumab monotherapy, overall response rates was, as a monotherapy, was inferior with a PFS was just 4.8 months vis-a-vis 10.8 months, as you could see in this observational study. And probably it's the way of, can we declassify these non-clear cell histologies into chromophobe, papillary, type 1, type 2, and exploit NGS-based therapy as probably could be the way to go. So with this, I conclude my talk and thank you for the patient hearing. Thank you.